Welcome to our live webinar titled Advances in Treatment of PNH. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you're unable to view the program online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your healthcare. Our specialist today is Dr. Jaroslaw Maciejewski, who is a staff physician in the Cleveland Clinic Department of Hematological Oncology and Blood Disorders. He is also board certified in hematology and internal medicine. He's the chairman of the Department of Translational Hematology and Oncology Research at the Taussig Cancer Center and has an academic rank of professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western University. In Case Comprehensive Cancer Center, Dr. Maciejewski is an associate director of translational research and a member of the executive committee. As a practicing hematologist, his clinical interest and expertise in bone marrow failure includes aplastic anemia, MDS, LGL, PNH, and pure red cell aplasia and myeloid leukemias. Thank you so much, Dr. Maciejewski, for joining us today. It's a pleasure to have you.
I am trying to share the screen. Thank you very much for the invitation. It has been like the last 20 years. From time to time, I do these talks, and it's always a pleasure to talk to the patients. Some of them might have seen me in the clinic, and I hope I am not going to be boring in terms of what I am going to tell, but I am going to start with a sort of very beginning and progress quickly to the most important issue, namely the treatment. I just, maybe up front, I want to ask that the audio and you can see me and hear me well.
Yes, we can.
Okay, well, we see a significant number of patients with PNH at the Cleveland Clinic, and over the last 30 years gathered quite a cohort of patients and experience in this field. That's why from time to time, the Friendly Aplastic Anemia MDS Foundation asks me to talk to patients and to present a sort of overview. This is probably new to people who are new to the disease, unfortunately, versus for those who have heard this story about the pathogenesis and mechanisms of the disease. Please bear with me. I'm going to get through, and then we get to what's new or what, and with a focus mainly on the treatment. So PNH, and I want to tell you that this is all in the context of the registry that is going to be announced. And, one has to see the PNH first in the context of rare diseases. And why is it so important that patients participate in research and in registries, clinical trials, or donate a sample if your doctor is an academician who does research on this disease? And this is due to the fact that rare diseases are inherently difficult to study. And this is because of lack of funding and advocacy. There is not like 100,000 people who would be there, including randomly affected, wealthy or influential people with this disease who would be very loud about the need of researching this. So we are sort of on our own, with the progress. It is hard to substrate for academic careers of doctors, and the clinical trials are difficult to perform. And for a long time, there was very little commercial interest. Now, the last point changing significantly because the first company, Alexion, that made the original drug that was first FDA approved substantial drug for this disease, actually makes significant amount of money and became very famous as an example that companies can use rare diseases to make profit. And this has been unknown to that time. And that's why, the success of Alexion was so significant and paves the way for other rare diseases to be studied, for drugs to be developed, because they sort of showed that it's a profitable endeavor to support rare diseases as well. For young physicians, it's difficult to attract them to do research in PNH because you need to have a large patient volume, and it doesn't shine as much as, research in so-called big cancers or other diseases that affect more people. However, what needs to be said that for patients affected by rare diseases, low prevalence does not matter. If the disease affects one person per million, it's still important to you, just as if somebody is affected by a disease that affects every 10th patient. And some diseases, such as PNH, sorry for the typo, have an important role, allowing for study of bone marrow stem cells, rules of blood cell production, role of complements, and effect of immune system on the function. So PNH is a model disease. PNH is a model disease that is important to study. I'm sorry, I have to. I'm going to call back. I'm sorry, I'm giving seminar. 1 second. This was actually a patient. This was actually a doctor from Milwaukee who is known to many patients with aplastic anemia and PNH who wanted to share a case with me. So I'm sorry for this. In any event, the bottom line is PNH was very emblematic to medicine because we learned a lot about hematopoietic stem cells, how blood is being produced, and other issues that are relevant not only to PNH, but are relevant to many hematologic diseases, such as blood clotting and what causes blood clotting and how can we prevent blood clotting and what to do about it. So the role in medicine of rare diseases is bigger than socioeconomic importance of these diseases, okay? And I am going to go back. So, but in any event, to accelerate the progress in rare diseases such as PNH, we need patient engagement, participation in clinical trials, sample donation, and registry. Participate in registry as a tool to collect data. Now, the global PNH registry has a purpose to collect data to identify problems, to identify issues, to gain knowledge about what's important to the patient, what's need to be treated, what measures help and which don't, and to fill the current and future gaps in research. It also empowers the PNH community. Patients have access to a steady stream of progress, and they are more in control of what's going on and happening currently. So I encourage everybody to participate in this initiative by Aplastic Anemia Foundation. And, you know, it takes time, and sometimes, you know, we know all the role of questionnaires and, you know, whether it's per telephone or online, but it's really important that everybody participates, that we collect a lot of patients over a long time, because we can answer their very significant questions and that are helpful then to design a drug, treatment strategies, or do research in areas that are relevant. Now, I'm not going to spend much time talking about the patient registry because I think Aplastic Anemia Foundation, but you know, the key features are it is easy to contribute, the data is made anonymous, there is access to collected data for patients, the participation is ongoing, it will have periodic updates, and it's important to know that Aplastic Anemia Foundation might share the bulk data, the identified or compound data with individual or institution conducting research or preparing clinical trials. Now, what is PNH? Historically, PNH has been first described by Sir William Gull, who was a physician in Great Britain, and he was a royal doctor to Queen Victoria. And he first noticed the disease and describes the symptoms, which was in the late 19th century. It's paroxysmal because it has sudden onset. It's nocturnal because main symptoms that were described at the time where disease was discovered were connected to night. So the symptoms occurred at night and were noticeable mostly in the morning. And hemoglobinuria because the hemolysis occurring at night would result in collection of the urine, and the first morning when patients wake up and go to the bathroom, the bladder contains urine collected over the night and is usually red, and this is hemoglobinuria, not to mistaken with hematuria, which is presence of blood cells in urine. Hemoglobinuria is presence of hemoglobin in the urine. In other words, the red cells are lyse. It's very important because hematuria is a symptom of bladder cancer, bladder infection, and bladder stones or kidney stones, whereas hemoglobinuria is clearly a symptom of hemolysis. Now, I want to give you a little bit of a compendium of names that are used in the context of PNH, so it's better understanding, and we are on the same, if you wish, on the same denominator when we speak about certain aspects of this disease. So very often it's said that PNH is a stem cell disease or hemopoietic stem cell disease. So what causes PNH is a mutation, so small change in pGA gene in a hemopoietic stem cell that leads to a defect in the production of an anchor protein or many anchor proteins that ties other proteins to the surface. So the stem cell is a mother cell of all cells, and the ultimate stem cell is fertilized egg. But then the embryonic stem cells, and we hear a lot of political stuff about embryonic stem cells, how important it is to study them, how some people don't want to study them. But in any event, the embryonic stem cells then subdivides in the individual stem cells, including blood stem cells, which sit in the bone marrow and are the mother cells that produce all blood cells. So this is not an embryonic stem cell, but hemopoietic stem cells as a daughter of this very early embryonic stem cell. Now, what is important to know is that the hemopoietic stem cells, once they produce blood, then they can acquire mutations, and among many hematopoietic stem cells, the ones that acquire a mutation in PGA gene are the ones, these are so-called PNH stem cells, they produce PNH blood cells. And because the stem cells is defined as a mother cells of all blood cells, if you wish, PNH is characterized by the presence of PNH red cells, PNH white cells, and PNH platelets. Also, platelets are at least studied clinically, and perhaps the less understood portion of PNH. Now, if you can imagine, this box stands for the gene. Genes are these pieces of DNA that code for proteins and are essentially, they code for a prescription how to build a human organism, which consists of a lot of proteins, which are encoded for a lot of genes. PGA gene is one of these genes, and this is mutated in PNH. And again, these mutations are in hematopoietic stem cells. If we go here, the mutation happened not at the level of embryonic stem cell, whereby it would be inborn and the mutation would be in every cell of the body. This is not what's happening in the PNH. That's why PNH is not hereditary disease, but it happens in a stem cells in which produce blood. Okay, so this PGA mutation in the bone marrow stem cell is then affecting the progeny, the daughter cells that are derived from the stem cells, and these daughter cells include red cells, platelets, and white cells. Now, again, this is a PGA gene. Now, one would ask, okay, the mutation happens. If you wish, a mutation is a tiny defect in a gene. So why this tiny defect in the gene causes that the stem cell of PNH origin take over bone marrow like it happens in patients with PNH? Well, it happens to be that PNH evolves in the context of autoimmune diseases of the bone marrow, chiefly aplastic anemia. In aplastic anemia, T cells, which are the immune cells that control evolution of cancer, control the bacteria and viruses, these are the, if you wish, the T cells are policemen of our body. These T cells, in conditions of autoimmune diseases, such as aplastic anemia, for whatever reason, become reactivated and attack our own stem cells. Now, this is pretty much like a rogue police department or a bad cop, if you wish, that does not distinguish a good guy from the bad guy. So this causes aplastic anemia. And in the context of aplastic anemia, what happens is that the PNH stem cells that acquire the mutation randomly are being preferred because they are not being eliminated by the T cells. Therefore, in the context of aplastic anemia, PNH stem cells and the cells that are produced by PNH cells are expanded. Now, how does it tie us to the symptoms of PNH? As mentioned, PGA gene that is mutated in aplastic anemia, that is mutated in PNH, codes for many surface proteins. Some of them are necessary to protect our own blood cells from complement, which of course produces a question, what in turn is complement? Well, the defective PNH stem cells and derived blood cells don't have a complement protective elements on their surface and are susceptible to complement mediated lysis. Complement is a system of proteins. These are essentially proteins that under normal circumstances attack bacteria or virus infected cells in our body and eliminate them. The normal or healthy blood cells are usually protected, but not the ones derived from PGA mutated PNH stem cell. These ones are susceptible and they are treated as they were foreign, as they were invaders, and therefore are being destroyed. We call this process as lyse or burst. Okay. Now, the complement pathway is very difficult, and I would say that minority of doctors could rehearse the complement pathway, and I don't want you to learn it. Needless to say that there are certain key points. It works like a chain reaction, that one particular element is needed to activate the other element, which is needed to activate the other element, and finally, complement destroys the red cells here. Now, there are certain key elements, if you wish, you can consider as doors, whereby certain locks can be opened by certain keys in order to get through this corridor to the final activation of complement and the destruction of red cells. And these elements include factor B, factor D, C3, and C5. This is for all purposes of this talk sufficient to understand how the potential therapies will work for PNH. Now, so what happens when red cells are being destroyed? So again, I just rehearse from the very beginning. PNH is a disease of hematopoietic stem cell, not embryonic stem cells, and hence is not inherited. The hematopoietic stem cell mutate in a gene which is called PGA gene. Not all of the cells mutate, but only one of them, and this one cell is preferred and expands under condition of immune attack, such as anaplastic anemia. As a result of PGA mutations, PNH cells derived from this mutated stem cell lose certain proteins from the surface that protect them from attack of complement, which normally is which is used in the nature to eliminate virus-infected or malignant cells. And therefore, complement destroys predominantly PNH stem cells, PNH red cells, causing a process which we refer to in medical terms as hemolysis. During hemolysis, hemoglobin is released to the plasma, and as such, it's passing through the kidneys. And as I described at the beginning, how Sir William Gull, the doctor of Queen Victoria, first described, the patient wake up in the morning and have red urine because they have hemoglobin in their urine. Okay. Now, what does it cause? First of all, we become anemic. This is a tremendous loss of iron, and it may lead to kidney damage in the long run or many other diseases. But one other very important complication of hemolysis is that hemolysis is a setup for blood clotting. Okay, so which brings us to three cardinal symptoms of PNH, namely hemolysis, propensity for blood clots, and decreased production of blood cells. Okay, now these issues, these cardinal signs of PNH lead to individual symptoms, such as symptoms of thrombosis, namely swelling of the legs, shortness of breath, abdominal pain if the thrombosis happens in the liver. Shortness of breath can be due to other factors such as pulmonary embolism or due to simply anemia. Abdominal pain when the blood clots happen in the liver or in abdomen. Fatigue when patients are anemic. They see red urine, which is called hemoglobinuria as described, and sometimes when hemolysis happens in certain organs, such as in your esophagus, it causes dysphagia and pain, chest pain, that very often is mistaken for heart attack. Now, what are the therapeutic approaches? How do we affect it? If most of the symptoms of PNH, including clotting, but mostly anemia, are attributable to hemolysis, the question is whether we can block hemolysis in PNH. And historically, this has been attempted by using steroids, anabolic steroids, One could also try to increase red cell production by giving EPO. If the bone marrow is affected by this autoimmune aplastic anemia, one could give cyclosporin or other immunosuppressive agents. This is particularly effective if reticulocytes count, namely the number of immature red cells detected in blood, is very low. This is a sign of lack of production that can be boosted up just to simply better compensate for the destruction. And also, now lately, drugs have been designed that blood complement activation, okay? And these drugs have been, now in the forefront of the effective therapies for PNH, versus in old days, the few measures that we have was to give prednisone or corticosteroids, transfused, hydrate, or give anabolic steroids such as danazol, okay? So I am not going to concentrate to talk about the role of these drugs such as cyclosporin and tacrolimus or anabolic steroids or prednisones. These are interesting issue, and given availability of more effective agents, these are really cosmetic measures, if you wish, for in terms of the evolution of in terms of the therapeutic efficacy. So yes, in certain circumstances, it might be helpful to add cyclosporin or use a little bit of prednisone, but really the hemolysis should be, and thrombosis should be treated with complement inhibitors. Now, you remember this complicated picture of complement activation with these doors that have to be opened by certain keys, such as factor D, factor B, C3, and C5a. These are the key points or key doors on this during this hemolytic corridor that leads ultimately to destruction of red cells. Now, it happened to be that these particular key points are targets of therapeutic development. Factor H is also an important factor. In fact, originally they were drugs that were directed against factor H, but this development has not been pursued in lieu of maybe other more promising at that time approaches. Now, currently we have 3 FDA-approved drugs, one affecting blocking complement at the C3 level. This is Empaveli, and ravulizumab and eculizumab are 2 drugs that are available for C5 inhibition, which is very end point of the complement activation cascade leading to the hemolysis. Now, as you can see, pegcetacoplan can act sooner in this cascade, and therefore, in certain circumstances, as might be considered beneficial, because some of the hemolysis is mediated by C3 and not C5. And if we block it at the C3 level, we, if you wish, block both C3 and C5 mediated hemolysis. Now, so Ultomiris and Soliris are the 2 drugs available. There are other drugs that are coming, which is crovalimab and pozelimab. I'm going to speak a little bit about crovalimab because it's later in the development. In any event, most of patients who are treated for hemolysis receive Ultomiris, which is IV infused every 2 months, on Soliris every 2 weeks. And these drugs have very good efficacy in terms of the C5 mediated hemolysis. Significant, most patients are improved with these drugs. This is the truth, but few patients are not improved, and many patients, the improvement could be better. And this is due to the fact that the blockade happened at the C5 level and not at C3 level, for which we have now another drug, which is called pegcetacoplan. And this drug, also known as Empaveli, is now currently FDA approved, and it blocks C3. And one of the benefits of this drug is that, of course, it prevents not only C5, because you cannot activate C5 without C3, but it also will prevent C3-mediated destruction of red cells. It blocks not only the main highway, but also essentially the other streets that lead to the same result, hemolysis. It blocks the alternative pathway, if you wish, of complement activation. So, it's similarly effective to C5 inhibitors, but in those who don't respond to C5 inhibitors, this drug might be really a treatment of choice. And, in those who have a very good response to C5, this might not necessarily be advantage. And we are going to talk about certain scenarios in a second and certain pros and cons to these drugs. I'm going to mention two other drugs, namely Factor D, which is made by BioCryst, currently in clinical trials, and Achillion, which a company that was purchased subsequently by Alexion, has a drug which is called danicopan. And danicopan blocks, if you wish, the hemolytic cascade very early on. So it blocks C3, it blocks C5, it blocks everything to begin with. And the beauty of it is that it's not an antibody and therefore can be eaten, can be taken by mouse. Now, this drug, danicopan, appears to be very effective in those patients who are on eculizumab or Ultomiris who don't have optimal response, and is currently being tested also as a single agent without IV. Okay. Now, another drug, which is called LPN-023, okay, this drug is produced by Novartis, and this blocks Factor B, slightly below Factor D, if you wish, in this cascade. And again, it has the ability to block C3, block C5, but blocks anything along this pathway, is oral, and it has been very effective. And it looks like in preliminary studies, it's not only effective in conjunction with C5 inhibition, but also by itself. So in other words, the patients who were on Solaris and Ultomiris were switched over or were at a certain point on both drugs, and then they stop the IV drug and they do well just simply being on this oral medicine. So now I want to summarize current and near future therapies, right? We have currently FDA-approved eculizumab, ravulizumab, both C5 inhibitors, and pegcetacoplan. This is Empaveli, which is a C3 inhibitor. There are certain differences. I think nobody is using, unless it's some sort of interventional inpatient setting, eculizumab, because it's short acting. The every 2 months infusion is by far more convenient. The results of comparison between these two showed non-inferiority. In other words, that the Ultomiris and Soliris have very similar effect in terms of the number of responders, about the quality of response, and side effects. So at least this can be said. But again, there is a certain rate, very small rate, of patients who have not sufficient benefit from these two drugs. And this is where C3 inhibitor was first developed for, but subsequently has been shown that the Empaveli can be also replacing C5 inhibitor, and by this virtue, you not only improves the non-responders to C5 inhibitors, but maybe a standalone drug, and is not worse, but might be better than C5 inhibitor in a lone setting. Now, again, this is if the effects were similar in a patient, and if one has a benefit of knowing it, one could say, hey, I leave it up to you whether you want to come to the clinic every 2 months and get the infusion, or whether you do it yourself, but it's twice a week, roughly. And these are 2 needles. You have to use this gadget to infuse it. And some people prefer one or the other. But, you know, I mean, clearly for those who don't have good response to C5, this is a choice, right? They would feel more motivated to do this. In the upfront setting, for those patients who consider starting one of the other drugs, we don't know if we knew that they would be a very good responders to C5, then this might be a better choice. But we don't know that. And we know that the C3 inhibitor will be better in those who didn't respond to original C5 inhibition. Now, what they have done, also, they developed two different companies. This is, you know, the danicopan was developed by the company called Achillion, which was purchased by Alexion, and LPN23 iptacopan is developed by Novartis. These two oral agents put tremendous pressure, as well as the C3 sub-Q self-injected drug, on Ultomiris to innovate, and therefore this drug might come as a sub-Q for every 2 weeks. So the patient will get infusion IV and then can be switched to every 2 weeks by self-injection. These are 2 shots that patient has to give themselves every 2 weeks using a gadget that is provided by companies. Now, you know, the effects seem to be similar in clinical trials, and I suspect that this is going to be FDA approved very soon, particularly that this is the very same drug as ravulizumab, okay? So the only thing is whether by injection sub-Q into your skin by yourself, you can achieve the same therapeutic effect as by IV, and this seems to be the case. But, you know, it's very different when you talk to patients, say, hey, if I infuse ravulizumab every 2 weeks, every 2 months, I don't have to worry about anything, versus I have to think, I have to schlep with me this stuff, I have to worry that it's kept cold, etc., and I don't like needles. So this might be a personal choice whether one would want to switch from this to this, or if you have a choice of starting with this or this, you would go for every 2 months or sub-Q every 2 weeks. Now, the next drugs that might be FDA approved is very close because it showed very good effect is crovalimab. The study was done mainly in China because in China, they don't have these and these on the formularies, they cannot write for it. So it was easier to go to this country to test this drug, and it has been shown very good results. It's just another C5 inhibitor. Now, this company went right away to sub-Q administration, which would be after initial infusion injected every 4 weeks. So slightly better than this. The drug is very effective, but again, it's not expected to be much better in terms of the number of responses or quality of response as the existing C5 inhibitor. In other words, if somebody does not have optimal response to Ultomiris, crovalimab is, in my opinion, less likely to help him as any other drugs that affect other points in the hemolytic cascade. That's why we came here to danicopan and iptacopan. These are these 2 oral agents, the anti-factor D and factor B inhibitors. And these are twice-a-day drugs. Actually, original formulation of this was 3 times a day. And it's going to go, if it's going to be ever FDA approved, it's going to be twice a day. The trials for both drugs so far looks very good. The final trial for factor B inhibitor will be so-called switch study, where patient will be given a choice to who are already on it and have good response to switch to factor B, in other words, to oral 2 times per day, and whether they will have the trial will prove or disprove whether these patients have similar rate of response or maybe better response. So far, it looks like very, very effective. The factor D ultimately will be a single agent, but the company that has a drug, namely Alexion, thinks that the first FDA approval filing will be for those patients who are on C5 inhibitor and don't have optimal response. In other words, pretty soon, maybe next year, end of next year, there will be an oral agent which can be given to patients who are less than optimal responders to C5, and these patients will have a choice to go on C3 inhibitor, Empaveli, or add to their drug an oral agent, namely this danicopan, versus LPN, of course, would be effective in the same setting in the less than optimal or responders or non-responders to ravulizumab, but also will be available. And I think the company is going to file for FDA approval as a single agent, which will make the life much easier, of course. And I think, some people say, some doctors in meetings tell me, oh, patients don't take pills, so it's sub-Q is better. I mean, I have a hard time believing this, but, having choices is a good thing in life. Now, so there will be choices for therapy, there will be preferences, and that will be a rationally selected drugs for, if you know that C5 response is not optimal, you are not going to use another C5 agent, etc. The cure is not in sight, but more and more patients are turned to have normal life. And once the oral agents are available, it's going to be equivalent to take whatever, your vitamins twice a day only. So it's going to become a manageable condition, which is a good thing. They are concept for curative treatment, and of course, bone marrow transplant being one of them, albeit very risky. But definitely there are other concepts, but this would be more in the realm of further future, and I would be more than happy eventually to talk about this too. Thank you very much.
Thank you so much, Dr. Maciejewski, for the wonderful presentation. We do have some questions, and our first question is, are new treatments making pregnancy safer for women with PNH?
Definitely, and also, the pregnancies have been observed in some of these drugs randomly. As you know, people who are familiar with clinical trials, you're not supposed to get pregnant if you are on a new investigational agent. But we already know from ravulizumab, but with Soliris, we have good experience that the healthy pregnancy is very compatible, in fact, safer, while being on complement inhibitor. It's a fact of life that once a pregnancy progresses, there is much higher risk of develop blood clots, and also patients' blood production is lower. They develop anemia just from being pregnant. In addition, they have the disease, and therefore the use of this drug is widespread. In many instances, the current dose of this drug have to be increased to account for a greater need or lower levels of hemoglobin. The question that is controversial somehow is whether patients who receive Soliris Ultimaris during pregnancy, whether they in addition have to be anticoagulated. Now, if a patient is not on Soliris and Ultimaris, then because of the double risk of blood clots, we tend to give these women heparin, Lovanox, as a sub-Q self-injection. The question is whether women who are already on complement inhibitors, such as these two, whether they have additional benefit from being anticoagulated versus the risk of bleeding. And this is still a subject of debate, and and that is unsolved. And I think it's going to remain a sort of judgment call for many years to come, because clinical trials to prove one point or the other would be not feasible.
Thank you so much. Our next question comes from a patient who was on Soliris for 8 years, and it became less effective. They then were switched to Ultomiris for 2 years, and that then became less effective after 18 months. They're now on Empaveli for the past 14 months, and it has been more effective than either Soliris or Ultomiris for this patient. They'd like to know, do you think they can expect to lose effectiveness eventually also with being treated with Empaveli?
Well, I mean, there are many reasons for why these drugs might, with the time, appear less effective. First of all, it is possible that the disease progresses. As you know, these drugs don't change the evolution of the disease, the size of the PNH clone. Secondly, our body metabolizes these drugs, get rid of them, or grows in mass, and therefore the current dose of these agents might not be sufficient. And then there are other reasons, such as we grow older and time passes by, we acquire reasons for complements to be more brisk, be more, if you wish, twitchy, and therefore require higher dose or stronger complement inhibition. So the chances are that the same process will progress when you are on C3 inhibitor, on Empaveli, but we don't really know. I mean, there is too few patients who are long-term on Empaveli, and the good thing is there are at least 2 new agents that would be a good alternative to Empaveli in development. And I'm sure there are more agents in development, but 2 are relatively close. So there is no uniform reason why one would develop refractoriness, except for, simple fact in life that things, as we age, nothing becomes better. I just say only we become smarter, but this goes only this far. But otherwise, the reason why the effect of this drug might be lost in some patients are poorly understood, but might involve many things, some of them modifiable.
Thank you so much for that answer. Our next question would like to know, can regular exercise help PNH, and is ginseng a possible cure?
Yeah, I mean, I don't think that the exercise is a cure. Exercise, it's hard to make the point that the exercise would be not good for you. But of course, there are levels of stuff. As we know, lactic acidosis, if somebody does too intense of a training, might precipitate complement activation and might oversaturate the inhibitor and cause hemolytic crisis. So I think, the all wisdom of being moderate and smart about these things, and not too hard on yourself, applies to this situation as well. I did not hear, and I cannot envision the mechanism, but by which you can work yourself out of this disease by strenuous or increasingly strenuous exercise.
Our next question comes from a patient who is also using Empaveli and is having good results, but says the need for refrigeration is a big downside, preventing the patient from traveling. They'd like to know, will the 2 new oral agents need refrigeration?
The oral agents will not need refrigeration. The other sub-Q agents will need refrigeration as well. In fact, these drugs are very expensive, and the longer periods than a couple of hours without refrigeration might disqualify them. I still think that they would be good for, but the quality control and the FDA and the regulation are such that nobody wants to take the risk. So clearly anything injectable at that point on the horizon will have this limitation. Some of these things are packaged in a big boxes, so if you have to do it several times. Now, the good thing is that, of course, it's much easier to deal with a drug that is injected only once a month, right? Versus injected every 2 weeks versus injected twice a week, right? I mean, there is, it's much easier to handle this. But yeah, refrigeration will be needed, and the pills will not require refrigeration.
Our next question is, do you think PNH is underdiagnosed? And if so, how can this be improved?
I don't think that PNH is underdiagnosed. I mean, there might be patients who are unaware of it, whereby the doctors look indifferent, but this would be rather exemption for the rule. Now, what might be underdiagnosed is to have a PNH clone. In other words, have a biochemical evidence, laboratory evidence that there is a PNH stem cell in a given patient, but the amount of blood or the number of these stem cells that are affected is tiny enough so that does not cause overt symptoms that would prompt investigation and therefore discovery that patient has PNH.
Thank you. Our next question is, does the current C3 inhibitor, Empaveli, eliminate blood clots like the C5 ones do? Is there data about blood clotting from the factor B and factor D drugs?
Well, this is a good question, and it's not straightforward answer because the number of events of thrombosis is not high enough to give you the answer quickly. In other words, there has to be enough patient treated on this drug for a sufficient number of time in order to be able to compare it to what we know about the disease. So if you take 100 patients who are treated for 10 years, right? So this would be 1,000 patient years. And we know that in 1,000 patient years, one would expect 20 episodes or 30 episodes of thrombosis. Now, if we have another 1,000 patient years on the drug and this number decreases, then we can certainly say, hey, it decreases it. This is on the stringent way to prove beyond any doubt that there is an effect. From the theoretical point of view, if the drug controls hemolysis, and if it controls hemolysis better, then for all we know, it should also better control the thrombosis. So if it controls better hemolysis, it will control better thrombosis as well.
Our next question is, if you have been able to manage PNH for a decade with iron and folic acid, would it make sense to consider a pill option to provide organs a break from working so hard to reduce waste? Once you have started taking a medicine for PNH, can you ever go off of it?
Yeah, I mean, look, there is no physical addiction to it. And if something works, why would you go off of it? Now, the question is, have I observed in the last 20 years or 15 years that the blockade of PNH is available as a therapeutic, that patient stops the drug because the PNH got better? I have to answer that I have seen the cases like this. And, so in these patients, when the size of the PNH clone by white cells decrease, and became very low, then we know if somebody's PNH clone is only 2%, the best that they gain by the drug is 2% higher hemoglobin, right? Because the drug does not protect the normal cells beyond what PNH cell, beyond normal. It protects only PNH cells. And, we have observed in a couple of cases, in fact, I think you can find a paper online, describing this phenomena that in some patients, the clone started to decline and eventually became small enough that we just stopped it.
Our next question, this patient would like to know, are there any current studies on making diffusional agents more effective?
Infusional.
That could be what they meant, but that's not what it says. That's probably what they meant. It says diffusional.
Well, I think, the infusional agents, there is another antibody that is a combination with another infusional agent that decreases the production of complement. The crovilumab, the newer antibody. And then there is another antibody that is actually produced here in Cleveland, and small company which has trouble to compete with the big companies, that has a C3 monoclonal antibody, which is also infusional. These drugs, chances are going to get better, particularly, so they will have a better pharmacologic properties and might bind tighter. So they might become slightly better. Yes, but, whether this is where the development goes, I think the development will go to develop orally available agents, and that have higher potency than the infusional drugs.
Our next question is, if PNH affects all lineages of blood formation, why is the white blood cell level not discussed in the treatment?
Yeah, it's a good question. If you do studies of many patients that we have done, you see that the white cells treated with complement inhibitor slightly improves as well. You might not see it on your personal level, but if you add many patients, you see that there is a trend. And it has something to do with the fact that, similarly to platelets are also destroyed by complement. Platelets are not as fragile as red cells, which are the most fragile cell in blood. That's why we have hemolysis. But they are somehow fragile, but they are somehow between. They are not as robust and resistant to destruction as the white cells. So now, what is the molecular basis for white cells not being destroyed and red cells being destroyed? It's the fact that white cells naturally express other proteins that defends white cell from the action of complement. In other words, the protection is redundant versus red cells that have only one way of protecting, and if they are affected by PNH, this one way of protecting them goes away, and therefore they are more susceptible. I hope this was the topic of the question, right?
Thank you. Our next question is, are there any tests to determine if a patient has developed kidney damage after dealing with PNH for a long time?
Well, I mean, the simple way is to measure creatinine clearance. I mean, this is the hidden truth about, if I don't have severe anemia, will I benefit from taking, my body compensates. I have hemolysis, but my bone marrow is very vigorous. So I don't have really severe anemia. Now the question is but I have hemolysis, right? And whether this hemolysis in the long run is going to cause kidney damage. This is a good question, but it, of course, by far a question that is by far more difficult to answer. So the common sense would say, hey, if I decrease the hemolysis, this rate of kidney damage would be much lower, but the rate of kidney damage is not that high to begin with, right? So the simple way of knowing it is to measure creatinine and creatinine clearance and see whether we are good. You can also measure serum urine hemosiderin, And, it's believed that part of the kidney damage is due to the deposition of iron in the kidney, because the iron mobilized from destroyed red cells has to pass through the kidney to end up in urine. And so once you start taking something like, eculizumab or Empaveli, one could measure urine hemosiderin and see whether it's getting less. But on an individual basis, clearly patients who have other insults to their kidney, diabetes, hypertension, some other kidney disease. Of course, in these patients, PNH will add more to the progression of the disease than in patients who have otherwise very healthy kidney.
Thank you. Our next question is there a similarity of blood clotting risk between PNH and COVID? And if so, is PNH caused by a virus?
Good question. There was a lot of, excitement about use of this PNH agents in COVID. The studies were not completely negative, but they were clearly not a home run. And it could be that under certain circumstances, this might be helpful. But yeah, what triggers PNH? It's a question that ties into the question, what triggers this autoimmune attack on the bone marrow that causes, remember I described this immune cells that serve as policemen, as cops, and they are good cops and bad cops. The bad cops overshoot and overreact. And this is what essentially aplastic anemia is. And if you wish, the PNH cells are less good of targets, or they are more stealth. They cannot be recognized as well under these circumstances. Now, why this overshooting immune reaction happens? This is a good question. And one of the long-standing hypotheses is that it's caused by the virus, by a virus. Now, is it a known virus under genetic circumstances, or whether it's a brand new virus that we did detect? I have to say that I have now currently in the lab an ongoing project where we want to, through special new technologies, be able to screen for all known viruses and go through these rare diseases such as PNH, aplastic anemia, and there are several others, whereby doctors for generations hypothesize based on this sporadic and attack-wise, seemingly out of the blue mode of evolution, that there was hypothesis always that there is an agent that causes. What speak against the agents, of course, that there is no small epidemics, that there is no, sort of, oh yes, there is an outbreak, everybody get PNH in a family or in stuff. So there are other things that are, of course, arguments that no, this is not the case. This is not acquired because of the exposure to a virus. But of course, everybody knows, similarly with COVID, some person gets COVID, ends up in ICU on a breathing machine. The other person gets COVID and says, hey, I had a little bit of headache, or I didn't even know that I have it. So the fact that we don't get, a sort of epidemic centers of PNH or aplastic anemia like we would expect in the infectious diseases, classical infectious diseases, is not quite satisfactory, because one could think about circumstances that you have two individuals, they are infected with the same virus, but because of his genetic background, he doesn't get it. And because of this genetic background, he gets it. Similar like you with COVID. So I think, it would be incredible to be able to find an agent that causes this disease, if such agent exists. And on and off, in the last 20 years or 30 years, I had projects that went for a couple of years, even funded by government, to find such a such an agent. And now I am, for, to be, to give you a secret, I'm again in a phase where having now available better technologies than I had 10 years ago, would like to revisit the issue of an agent that triggers PNH or aplastic anemia. And I think this might be a similar agent. In other words, it's a combined question.
Thank you. How does a PNH clone decrease? Does this happen spontaneously?
Well, there are several possible scenarios. I mean, the best case scenario would be that the normal cells become better and better than normal, the non-PNH cells. And therefore, the advantage of PNH cells becomes less and less. So this is, if you wish, a competition between the normal guys. So if the normal guys are sick, PNH cell or are weaker, PNH cells can have easier time to dominate. Not as easy as leukemic cells. They are definitely less fit than leukemic stem cells that cause leukemia, but they can dominate. Now, if the stem cells, the normal stem cells, improve in their health and quality and quantity, then one could envision that they eventually compete better and PNH clone exhausts itself, just, cannot compete and therefore goes away. This would be a good case scenario. The bad case scenario is in patients who have big PNH clones and don't have many normal stem cells. If the PNH clone exhausts itself and dies out, then they would have aplastic anemia because they don't have normal cells that would produce blood. And final scenario that, in my opinion, and again, there is a paper, you can look it up, that could happen is that we have a third player, in place. In other words, they are normal stem cells, they are PNH stem cells, and they are dysplastic stem cells. And they might be not very malignant, but they are definitely more competitive than PNH versus normal cells. So in other words, this dysplastic clone or a hemopoietic clone that is defective in another way, that this clone increases at the expense of PNH clone.
This question is, will a patient be able to switch to an oral agent even if Ultomiris has been working for them?
The planned study will stipulate that patients who have optimal response would be switched, of course, for the period of time that gives you the answer. I mean, if you get worse again, then you can maybe switch back. But these patients, so the stipulation is absolutely yes. I think this is a plan. This is a business plan of the company.
And how does alcohol consumption affect a PNH patient? Is it okay to have one glass a day and not cause any negative effects over time?
Well, again, I mean, passing out of alcohol and, breathing shallow, get acidotic from alcohol poisoning cannot be good for anybody, but in particularly in PNH might not be good. It's hard to be a stickler. It's very easy to prohibit everything. But, again, in a significant moderation, it's hard to make a rational, scientifically supported point that it would be a bad thing. On the other hand, it's very easy to say, hey, I don't want you to drink, period, goodbye.
This question comes from a family member. Actually, her husband has been diagnosed with PNH for 12 years, and the C3 and C5 inhibitors are not available in their country. Her husband has been taking prednisone and folic acid, and they'd like to know, is there a treatment that could make her husband live even longer, even though he is not on any inhibitors?
Well, I mean, there is no easy answers. I mean, obviously, you have to optimize everything. So folic acid is reasonable. If patient is anemic due to iron deficiency, take iron. If patient had blood clots, take blood thinners. If patient didn't have blood clot but has a PNH clone and signs of that might get blood clots, such as positive D-dimer, then of course, then of course anticoagulation would be in place. Hopefully, particularly the oral agents will be available soon. And as we know, there is a lot of other ways, they will be pretty much copycats, they will be patent issues, and eventually oral drugs will become more and more ubiquitously available. I just remember when I was young doctor practicing in Reno, Nevada, and I had to have my senior doctor in the VA clinic sign against Prilosec, the lila pill, because it was so expensive and it was highly restricted. And now you can get it over the counter. I'm not proposing that PNH drugs will be available over the counter, but definitely, availability of oral agents across the board is going to change the equation, because obviously, it's easier to ship, it's easier to administer, you can self-administer, you can, if you wish, in countries that the regulation is strict, you can organize it. So availability of oral agent will definitely be increasing the chances that everybody gets it.
Are you aware of any correlation between PNH and low copper levels?
I'm not aware of correlation. I measure very often copper levels. Usually patients with copper deficiency have normal or high platelets. There is no stringent correlation, but it's a sort of cool question. Measuring a lot of copper throughout many patients, it's very rare that you find patient deficient. The typical symptom is leukopenia and anemia, and it's very satisfactory because with a very cheap and easy treatment, you can fix these people. The question is there any additional contribution of copper level or copper deficiency in patients with PNH that we are not aware of? But it's a good question. I'm going to investigate. But the easiest way to find out for yourself is to ask your doctor to order copper level.
Thank you. And our last question is, you spoke about the registry earlier in the presentation. Can you speak again about the benefits for patient joining the registry, and how does this help PNH experts?
Well, I mean, my personal experience with registry is such. I remember I came up with kidney stone, and I went to urologist, and they had some registry in the waiting room. And while I was crumbling from pain, they asked me to answer 150 drooling questions, and I thought that I'm going to smash the tablet against the wall because I was in such a pain. So having said that, registries are very important because they focus the doctors on things that are really important to patients. They allow us to collect a lot of data in a short time from many institutions, so they are not institutionally biased. And of course, registries have a lot of disadvantages, less control, patient can answer, patient might be not truthful, and so on. But this is all offset that much higher number of answers can be gathered in terms of the questions that we have. And even if there is one less stringent answer, or somebody didn't pay attention or made an error intentionally or unintentionally, it's going to go under because enough patients answer a particular question. So, in rare diseases, what is our hope? Alexion broke the ice because, as I mentioned, it showed you can make money from rare diseases, for good or bad of it. But that's why we have the drugs. If Alexion would have made an effective drug for PNH and go under in a process, would be very little hope for develop of an orphan disease drug. So this is a good thing. On the other hand, the advocacy is less. So the individual patient has to be more voiceful, more engaged in things that make a progress possible. So that's why the registries are important, helpful, and I know sometimes a little bit annoying, but look, what can we do? Everybody wants to be able to contribute a little bit, and it gives you a certain satisfaction that, even in smaller contribution is significant.
Thank you so much, Dr. Maciejewski, for sharing your time and your expertise with all of us today, and spending extra time answering all of those great questions from our participants. If you have any additional questions, feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org. You can give us a call at 800-747-2820, or you can submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thank you so much, Dr. Maciejewski.
Thank you.